heart attack patients and has been actively involved in teaching, mentoring medical students and senior residents. Prior to Singapore, Dr. Rastogi practiced as a consultant in interventional cardiology and heart failure in Greater Seattle, USA, further enriching his diverse clinical experience. Today, Dr. Rastogi will enlighten us on a topic of utmost importance, heart disease among healthy people, the risk of low risk. In an era where increasing number of individuals are presenting with heart attacks, Dr. Rastogi aims to educate us on the non-conventional cardiac risk factors, shedding light on crucial insights that could potentially save lives. Before we get into the enlightening discourse, I would like to extend our heartfelt gratitude to Embassy of India and JNICC for graciously providing the venue for this event. Without their generous support, gatherings like this would not be possible. So without further delay, let us warmly welcome Dr. Saurabh Rastogi as we embark on an enlightening journey into the world of cardiology. Thank you.
Good afternoon, everyone. Thanks for coming on a Saturday afternoon to hear this talk. I just hope I make it fruitful enough for all of you to take something back home. And thanks, William, for arranging this and for my visit to come here. Okay. So, without much ado, as he said, we see a lot of people these days developing heart disease when they're fairly healthy. And the whole aim is to try to make you understand what are the other things that could be contributing to it.
Just a slide changer.
Okay. That's what the topic says, right? Okay. Yeah. So, like you can see, I'm an interventional cardiologist. I think you'll see a lot of newspapers, news articles in India talking about how we are a very corrupt brand of doctors putting stents for money or putting inappropriate stents. I actually had a dear friend who I happened to put stents in, so he always keeps sending me articles. Either AI is replacing medicine, or interventional cardiologists are going to jail or being, banned. So I'm just waiting what will end my career, whether AI or corruption. We'll see. Till then, I count my blessings to be able to take care till I can. Yeah? Yeah. It's not coming on full screen.
No, it's not full screen. Can I check?
Yeah, it's happening.
No, but are people able to see it?
It's coming on. Okay, yeah. So this you guys will find interesting. So I hail from a small town in India. It's called Moradabad. It's near Delhi. It's known for its brassware. And after that, Robert Videra, who's Priyanka Gandhi's husband, was my neighbor in Moradabad. So that's our, claim to fame. But anyways, my grandfather, he was the first doctor who in Moradabad back then. Okay, all right. And he was a practicing radiologist and a TB specialist back in the day. And I used to go to a boarding school, and then one fine year, this is 1989, he was, I think, 70 years old. So I came back from my holidays, and I was told that he underwent an open heart surgery. So at the age of 70, he had an open heart bypass surgery. Then later, at the age of 90, he got a stent. And at 100, and at age of 100, he became the oldest practicing doctor in India.
Wow.
So he was inducted in the Limca Book of Records of India as the oldest practicing doctor in India at 100, and then he passed away at 103. But somehow when I came for my holidays, I was in grade 5 at that time when I heard about this. So that got me interested in cardiology, about the heart. I still remember making a project for my school. It was called Know Your Heart. It even won a prize at the time. But yeah, that's where my journey started. For some reason, I stuck to cardiology since then, and that's how I'm here today. So I went to medical school in India at Maulana Azad in Delhi, did all my further training in the US, moved to Singapore in 2015 and Glen Eagles in 2022, and I see Singapore as home for the foreseeable future. Yeah. So I think Bollywood really resonates with Indians, right? Anything happens in Bollywood, from politics to drama to good movies, it moves them. So do tragedies of Bollywood, right? And everyone gets really excited or concerned when they see young people having heart attacks, dying of a cardiac arrest. And that's what gets people thinking a lot, what's happening, why are these young people having heart attack, heart disease. And some people pay more attention and then some just move on with life. But yeah.
Every time it switches, it stops. Sorry about that.
It's not coming full screen.
Yang tahu bagaimana ya? You don't know? Sorry. नहीं हो रहा है.
The setting of screen resolution.
Yeah.
So, yeah.
Can you just?
Huh?
नहीं हो रहा है.
Just continue that.
Yes, please, please just speak. नहीं हो रहा है. यहाँ तो और कम करेंगे. Saurabh, maybe you should just continue. It's not happening.
No, make it 100% is coming, no?
हाँ जी.
You login from this, so that you can edit the
I know you from.
You login from this as a host.
I think you know.
Please make it clear.
Okay, give me a second.
Yeah.
Okay, so shall I? Now you can. You can leave the meeting. Okay, so now I don't need to reduce the display. Give me a second. Speak a little.
Yeah, so that makes it, that's why I called it the risk of no risk, is the fact that you think you don't have, and you're not at risk, but we are for other reasons. And the talk is to highlight those reasons. So going back to just surveying the population, this was out of Singapore, about 9,000 patients with heart attack, about 10% again had no standard risk factors. This is a bigger global study of about 1.2 million people. In them also about 10% had no standard risk factors. That makes it a pretty large population of people who don't have your regular risk factors. So what are these novel risk factors that we talk about, right? And essentially, all this is all lifestyle related for most part, from mental health, sleep health, obesity, sedentary living, the kind of diets we eat, infection, pollution. And if you have to reflect over the last 40 years, why are we here? Like, how did we get here? You know, from a time of our grandparents or younger years for some of us who are now in the 50s or 60s, and even for myself, or how do we actually get here? So the few things that came to my mind, and you think about it, right? So internet, social media, industrialization, more urbanization, people leaving homes from communities to nuclear families, going to big cities for corporate jobs, climbing the corporate ladder. You get more time poor with all these, achievements you want. And the more time poor you are, the more processed food or fast food you eat. The age of internet games and video games, kids mostly, sitting home and playing video games rather than being out there and playing. And then pandemics like the COVID we had recently. So all these things kind of contribute to these lifestyle risk factors in some way or the other. They're all interlinked. Nothing is mutually exclusive, but it's a real problem. Our lifestyle is a problem. It causes these things among us. To some extent, some of us become victims of it, some of us won't. And that's the key, how to identify who's having a problem or not. So how these things create a problem of increase the risk of blockages is by this concept called increased inflammation. So these are some terms I need you to start remembering. Inflammation will be one word which will keep coming again and again. And this increased inflammation basically increases the risk of heart disease. All right. So the talk today, I'm going to work backwards. We'll talk a little bit about heart disease, so that you're on the same page of what heart disease we are talking about here. We're talking about blockages, heart attacks. Then I'm going to tie in how inflammation increases the risk of heart disease and how these risk factors cause inflammation. So that's going to be the flow of the talk. So just to recap, we all know heart is a pumping organ of ours, which pumps all the regular blood to all the vital organs. You know, if it shuts down, our body shuts down, we die. And that pumping heart has, three main arteries, which are the lifeline for the pump that help supply the blood supply.
USB दे दीजिए.
इसमें से स्लाइड शेयर करता हूँ जो लाइक
Sorry about that. Our online participants cannot see the slides, so we're just using the USB to share. Till then, we can see the heart beating.
Beating faster. It's beating faster. Okay, we're still struggling here. So the three main arteries which supply the blood, right? And these days you may have heard about the CT scan. That's the next big thing we keep hearing in my talk again and again. It's the new technology which helps you see the arteries non-invasively. You can see all your three main arteries, just like the beating heart. There's one on the front, one on the right, one on the left. If I take the muscle out, that's what it looks like. You can clearly visualize all the three arteries that supply blood to your heart. And you can also assess if they have blockages or not. These are in healthy people who are generally doing fine. A blockage looks like this. The white line, like if this is normal, it narrows down. That black stuff is actually the blockage or the plaque. And the white stuff here is the calcified plaque. Now it's the same thing that I see on an angiogram. Let's see if it works. So that's the angiogram which we do in the cath lab when we do stenting and all. That's how we look at the arteries. But the point I'm trying to make is it's the same. It's visualizing the three main pipes that supply blood to your heart. You can visualize them on CT scan. And then if there are problems, the angiograms help to visualize it. All right. So that's how we detect plaque today. And this CT scan, through the next rest of the talk, I'll highlight how important it is. So now, what is heart disease or heart attacks? How does that happen? So basically, the so-called blockage of plaque, people call it fat deposition, cholesterol deposition. They call it, in different words, but basically this yellow stuff which starts depositing, it's the LDL cholesterol which you all measure in your blood. That's one of the key particles that enters the arteries and starts creating the blockage. Now, that is related to all the risk factors, help promote it, and it slowly grows. It'll keep growing, and it becomes bigger and bigger. And sometimes it's big enough that people notice they're having exertional pain, exertional shortness of breath. That's when they might go see a doctor and then they have serious blockages. Or other times, what happens is this blockage ruptures. That's what causes a heart attack. When suddenly your blood vessel shuts down like this. The blood supply to that part of your muscle goes. That's what causes pain. And that's what you go to an emergency as a heart attack. So that's called a heart attack. This is an example of a heart attack where you see this artery. I told you they're all pipes, right? Think of it as plumbing pipes. And you see how narrow it gets there? That's the blood clot which is obstructing the artery. And this is after you put a stent, how it opens up. That's the blood clot which we took out from this artery. But that's a heart attack. Now, the next thing is cardiac arrest. Two common terms that are used. People say either someone had a heart attack, someone died of a cardiac arrest. They're basically a spectrum of the same thing. Heart attack happens and you lose blood supply to the part of the muscle. If the heart attack is so big and severe, the heart basically stops beating. That's what's cardiac arrest. It just stops beating, right? So this was a patient actually who I saw in my emergency room. He had actually come with a heart attack and he was having pain. By the time I came to see him, he was in this rhythm. This is normal heart beating, one beat is a normal beat. And right in front of my eyes, he actually went into a cardiac arrest. This is what a cardiac arrest looks like. Your heart stops beating essentially. We took him to the cath lab and so this is what is happening to his heart. One of his arteries had completely shut down, so-called blockage. You see here on top, and if you see the next picture, the same frame, you see now it's open right here. Okay. The artery is blocked here, it's opened. So basically, he had a heart attack, and then that heart attack went into a cardiac arrest. 30% of the people, the first time they have a heart attack, it can just progress to cardiac arrest. So that's how we hear people at home. They didn't wake up in the sleep. Someone is going on a treadmill. He passed, collapsed. It's because you have a heart attack. And just the way your body responds, the first presentation will be cardiac arrest, and you don't have a chance to revive that patient. And that's pretty much it. So when we see people with blockages, right, they ask us, what's the chance I'll have a problem? How big will my problem be? And there is no way to predict. I would explain to them that, yes, you may have a heart attack. Now, will it be a mild heart attack or a cardiac arrest? You can't predict that, right? So if you have tight blockages, they are substrate for heart attacks. And that's why when people do open them up, is because to decrease the risk of a heart attack or cardiac arrest. So the next question comes, how do standard risk factors or these novel risk factors increase the risk of blockages? I think the slides are too far for you to appreciate. But what I like you to understand is just remember two terms. All these risk factors, be it your standard or the non-standard, they cause inflammation. And that inflammation causes something called endothelial dysfunction. These two terms I really need you to keep in your mind right now, because if you understand this, it'll become very simple for you to correlate your general life risk factors. So what's inflammation? You're going to hear this word everywhere. Your body has more inflammation, you're having more heart disease, inflammation, heart disease. So inflammation, whenever you get an infection or you hurt yourself, that part of your body turns red, inflamed. That's your body's response to heal that wound. Or when you're having fever, it's your body's response to heal the infection. So your body, just like a country's army has their own navy, army, air force, and they take out their own ammunition from bullets to missiles, whatever. And they are these, they're called chemokines, cytokines, or inflammatory markers. So they are released as part of the process of protecting the body from any acute infection or injury. So in the past, we would talk about this inflammation is to protect you from these things. But as time has gone by, people have realized that if you have persistent injury, like a persistent stimulant, then this inflammation doesn't resolve because you've not taken away the stimuli. So today's stimuli is other lifestyle related risk factors. whether it be the diet, physical activity, mental health, all these are persistent stimuli for this inflammation to not settle down, and then it counteracts. It's like a military coup. It takes over your own body. It starts harming your body over time. So that is what is happening in inflammation. This is the most important slide. How does inflammation increase the risk of blockages? I've told you inflammation and endothelial dysfunction. I'll explain that. So I've taken the example, think about Mexico, US, and the Trump wall, right? The new wall they're building across. So that, remember this diagram I showed you, this is the artery, and that yellow cell is the plaque, right? That's building up. That is this plaque here. This is the LDL particles, the cholesterol particles that deposit. Now, those LDL particles, consider them as the immigrants. That's your Mexico is the artery itself. That's US, which is the wall of the artery. And this pink line is the lining of the artery. It's the endothelial cells. That's the actual lining of the artery that keeps your artery healthy. So if you have a very high cholesterol, super high cholesterol, it can overcome the wall and enter the artery and start depositing, and all the chemical reactions start. But let's say you have very less cholesterol, but you weaken this wall. And how you weaken this wall is by inflammation. Right? The inflammation weakens this wall, and so you can even have normal cholesterol levels. But that cholesterol, if this wall is weak, it'll start getting into the artery and causing blockage development. And so there was a study of about 4,000 people. They showed that people living with normal cholesterol and normal hemoglobin A1C for diabetes level, they had plaque in their arteries. So that's how it happens. And you can have normal cholesterol, no sugar, no blood pressure. But if you have inflammation for other reasons, the normal reasons, you can still start developing blockages. And that's the key part to understand. So to sum up so far, I've told you what's heart disease and how does inflammation cause heart disease. Next, I'm going to use some case examples of patients who have come to my clinic and hospital with these kind of problems, and just elaborate a little bit on the different novel risk factors. Yeah. So sometime back, this Edward Thomas, one of the ministers in Singapore, he gone in for a routine health screening checkup, and then he came out getting a stent in one of his arteries. It became a big article in the paper about how routine health screening found silent blockages, got a stent, got saved. And so someone read this article. There was this 44-year-old lady who read this article. She's overweight, little sedentary, and she had been having some off and on pain. And when she saw this article, she decided to come and get checked up, say, hey, I saw this, and I want to make sure that I'm okay or not. I said, fair enough. So this is her CT scan, and one of her arteries had quite a tight blockage actually, which was causing her pain. And that's what it looks like on an angiogram. And after stenting, we opened it up. So people come in weird ways. Different things drive people to come and get checked up. But this is how she had shown up. So obesity and heart disease, I think this is the biggest problem. All of us are going to be partly overweight. And as an Indian male, we genetically are predisposed to put on weight around our bellies. It is just the way we are built, most of us. And this fat collection is called visceral fat. That is substrate for all the inflammation. It creates a lot of inflammation, which then drives, I told you the terms, right? Inflammation, endothelial dysfunction. It causes that. It causes high cholesterol levels. It also causes insulin resistance, which will eventually lead to diabetes. But the problem is, most of the time people come to the clinic, if they're just overweight and they have low blood pressure, diabetes, or cholesterol high as such, they think they're okay. But on the inside, things are happening. And so they've done a very interesting study where they're looking at till 2050, from 2025 to 2050, heart disease related to be it blood pressure, cholesterol, diabetes, smoking, it's all going to go down because we are aggressively treating these risk factors. But it's going to go up like 300%. because of obesity. Because that you are not really, you're telling them to lose weight, but everyone's like, okay, we'll figure it out. You're definitely treating all the obvious modifiable risk factors, but that's the vulnerable population, which may be getting into problems. So always watch out for overweight. It is a real problem. It does create issues. Exercise is the best medicine that you can have. It is the best thing. It works wonders in many ways. It decreases the risk of everything from cancers to heart health to diabetes to just aging, frailty, you name it. Exercise will benefit. It's almost a 35% reduction of cardiac risk if you exercise regularly. And the way it works is by, again, suppressing inflammation, improving the endothelial functions. So it acts on it. Apart from physical health, it also helps with mental health. It's a great stress buster. It improves symptoms of depression. It takes care of your stress, anxiety. And actually, they've done a study on it, 50,000 people who have stress, and there's an area of the brain which actually lights up when you have stress, depression, all these mental illnesses. And they followed them for 10 years. And they actually found that the more you exercise, the lesser the signaling of this was. So it's a true phenomenon of how stress really helps. Biologically, they have proven it. So another case, this was a 46-year-old male, again, no medical problems. And all the cases I'm presenting, none of them have the standard risk factors. These guys have none of the regular risk factors. He was overweight, but he was active, gymming guy, well built, and he was having some off and on pain now and then. He went to an emergency room. They did his heart checkup with ECG, blood tests, everything. All that was normal. He was given a 6-month appointment to go see a cardiologist just to make sure, but he kept having symptoms. So we have two different systems, private and public. So he came over to see me, he said, let's just get it checked out. I said, fine. And that's what his arteries looked like. They had a lot of this hard plaque. It's quite far away. I'm not sure if you can appreciate it. That's what a normal artery looks like. That's what he had. And he was just 46. And his arteries were probably like a 90 or 80-year-old, lots of it. So we kind of asked him, I then, got further history from him. And he basically was having 10 meals a week of fast food, from Kentucky Fried Chicken to burgers to, you name it. Again, time poor, works in corporate, no time, stay with friends. All the meals are coming from outside. Fast food, processed food, which a lot of people do eat because they don't have time to cook food at home, right? So just eating a lot of processed inflammatory food. And that can cause problems independent of having any of the risk factors. Those were his blockages again. I don't know if you can appreciate this. We can actually have cameras to see on the inside how your blockage looks like. So you see how narrow this hole is. This is after putting the stent. And this yellow orange stuff here, that's all the plaque, all the blockage that builds up over time in the artery. And that's what a stent looks like when you put it in. So I think there's enough internet information on the food, different food choices, nutritionists, dietitians, life coach, health coach, and they'll talk to you about all kinds of good foods and bad foods, but there is truly a phenomena of good and bad foods. There are foods which cause less inflammation, and they keep talking about, green vegetables, fish, nuts, fruits. They are much more healthier than all the red meat, processed foods, fried, sodas, sweeteners. And again, it's a little far, but so there's one very interesting study, 200,000 people, all young, healthy people, 200,000. They followed them for over 20 years through regular questionnaires every 4 years. That questionnaire assessed how inflammatory a diet you were eating, just natural following. And actually, people who had a higher inflammatory diet had almost 40% chance of increased risk of heart attack, heart disease, than people who ate healthy. Again, they've proven these concepts. They're just not myths, the actual real concepts that they have proven. Then there's this whole new thing called gut health. They talk about gut health these days related to everything. And that, again, science is always evolving, advancing, there's research going on. And this is also a real phenomenon. your gut has many bacteria, which are called the normal flora, and they take care of how they break down products and do things. And all the red meat and the processed foods that we eat, when they are broken down, they create certain substances. It's called TMAO. Eventually, they basically go through your gut, breaks it down, it crosses the barriers, and these products actually cause significant inflammation to cause blockages and increase risk of heart attack. So that's how all these processed foods can actually harm you. So it's a real phenomenon. These are things that are really happening. Another guy, 44, overweight, very active. Actually, this one, he came to see me, very interesting story. He came down from Indonesia. He well built, kickboxing, super fit. One day he just felt some fluttering in his heart 2 months ago, before he saw me. He paid some attention, forgot about it, going about his regular activities. His wife was coming for a checkup to Singapore. He just came along, and since she went to see a doctor, he said, let me just go, by the way, to see a doctor, just for the one episode I had. He happened to fall on my doorsteps. So, of course, like I showed you, you've already seen ICT, everybody knows, because no point of guessing what's happening. He had a really tight blockage. Again, 90% blockage, and when I told him that, he couldn't believe it. He came to see me in the next afternoon. That morning, he had done 100 push-ups, water aerobics, everything. He felt great. He said, I can't believe it. Yeah, and it took him some time to digest that he was sitting on this blockage. And he, again, now when I talk more to him in hindsight, he basically high red meat consumption, at least 5-6 meals a week of red meat, and he was diagnosed to have sleep apnea. That's another problem that we have. So that's what his arteries look like. That blockage on CT is very accurate. You look at it, same, similar, very, very accurate. And that's post-stenting. So again, if he had carried on like this, for sure, it was a pending, with that kind of physical activity and strain, and that kind of a choke in your artery, it's a matter of time before you're going to have a major event. Now, a major event, will it be just a mild heart attack or a severe cardiac arrest? No one can predict that upfront. So, sleep apnea, again, it's part of the whole sleep health. The two things in sleep health, one is sleep apnea and one is sleep efficiency. Sleep apnea is basically at night when you're sleeping, the muscles in your neck soften, the airway collapses, the oxygenation goes down in your blood. You wake up, you'll of course not remember it. But a lot of people next day, they have headaches in the morning and the whole day they're very sleepy. That's what's happening to them because they're not having a refreshing sleep at night because of this sleep apnea. But when that oxygenation goes down in your blood, that basically, again, increases inflammation. Again, inflammation. So less oxygen, more inflammation, more risk of heart disease. And it's among 40-50% of people who have found to have blockages with no standard risk factors, they have sleep apnea. So I always screen the patient with sleep apnea if I really can't find the obvious cause. Yeah, this was another actually good friend, 44-year-old, no medical problems, high stress job, and very bad sleep hygiene, was sleeping at irregular hours, sleeping less amounts. Anyway, I get all my friends to keep coming and get scanned because, I'm looking for disease. And his cholesterol used to be 130s, but post-COVID, it went to 170. And we'll talk about that more later, but he basically had a high stress, bad sleep, and he too had very severe blockages, 2 blockages. In fact, he had both 90% in his arteries and he had no symptoms. Someone who I hang out with all the time, one of our close buddies. So don't know who's sitting with what, and even he was shocked about it. But again, he was 6 months probably at the most away from having a major event. But we got it in the process and they were fixed. So mental health and sleep hygiene, again, it's a big problem of urban living today. You can call mental health depression, loneliness, stress, anxiety, and it's not about one day. It's about a chronic, sustained, phenomenon. And they have actually charted it out. It starts in the brain. There's an area in your brain where all these mental, emotional strain acts, and that creates biochemical markers to create inflammation. It activates all those your inflammatory cells. It actually does. And then that's how you have plaque deposition. Same with sleep. If you're sleeping less than 6 hours, say 6 to 8, some people say 7 to 9, some others say that's an adequate amount of sleep for your body to heal, for your heart to rest, for your body to regenerate, recuperate. There's a normal cycle to it. And if you're not doing that in the right hours, you're going to be more tired, more fatigued. It increases your stress hormones. You tend to eat more, junk food because you're more tired. That's the food you gravitate towards. The stress hormones increase your inflammation. Your gut system goes out of control. Again, all those things put together create problem. And they have done studies showing mental stress by itself can increase your risk of heart attacks, independent of all other reasons. Like all things equal, it creates problems. So with sleep efficiency. If you're not sleeping adequate, or let's say you're lying in bed for 8 hours, but you're sleeping 4 hours, that's poor sleep efficiency. So they have ways to quantitate that. They have questionnaires to talk about it. And it's a real phenomenon. And it's not about one day, but you give it a few years of it, it'll catch up with you. This is the last case. Again, good friend, super fit, does spinning classes, name it, in all kind of physical activities. And he was having some poking pain, but not with his physical activity. And his LDL was really high. And again, pre-COVID, he said it was totally normal. So he was kind of shocked. These are all people who post-COVID started checking the blood and suddenly found their levels to be too high. And that's where the theory comes that COVID or the COVID vaccine contributed to some of these heart attacks or heart disease that we're seeing. But yeah, he too had some very severe blockages. He was also shocked for the high intensity workouts he did. And this is all silent disease. Pain is not like the typical pain, but it comes in different ways. Major blockage fixed. But the point is, how much did COVID caused this whole increase in cardiac events? There are a lot of theories around it. They have done data, analysis of millions of people, and there is enough noise that yes, the amount of cardiac events may be 20-30% more due to COVID or vaccine. Your cholesterol numbers may be higher. But the thing is, COVID is the one which is maximum studied. No one studies flu, no one studies pneumonia, no one done so much research around it. But basically, through COVID, there are many reasons you could have had this problem. It's a chronic inflammation, people got more, depressed or excess alcohol consumption, your gut microbe got, disturbed. So a lot of mechanistic hypotheses were proposed of how COVID may have created, but the same applies for any kind of infection. Infection creates inflammation, but if it's a hyperinflammation where it in fact harms your body, that's when heart attacks happen or plaque happens. And sometimes it happens with any infection. Because of that surge of inflammation, it can create problems. The same is also true for pollution. Not one day, but if you have sustained sitting in traffic in Jakarta, Delhi, Bangalore all the time, with your windows down, and you're inhaling or you're in industrial pollution, those particles actually, again, stimulate this inflammation, which can eventually increase the risk of heart disease. So, in summary, I've kind of tried to talk about how different novel risk factors kind of create this whole inflammation through different mechanisms, but central is inflammation, and then that's inclusive for heart disease. So the next question comes, can we figure out this inflammation? How do you figure out, because of our mental health, our obesity, are we having any problem that should be worried about, right? So there are lots of studies happening around biomarkers for inflammation. You know how you check your blood for hemoglobin, cholesterol? They're talking about a lot of things. Can you check something in the blood? There's a lot of active research. There's just one marker, it's called CRP, which sometimes high sensitivity CRP will do in the blood. It's got some correlation, and that's the best we have for now, but it's not perfect. But yes, I would check that. And there are two studies which have actually supported checking it, even with people with normal cholesterol, and you target them with statins, it has reduced the risk of heart disease. People have heart disease whose cholesterol is normal or LDL is very low, but if the CRP is still high, they're giving some anti-inflammatory medicines. It's helping. So there's some signaling that measuring this molecule will help and then target it. But there are ways to go. I mean, I think it's at least 5-10 years before we'll have anything concrete to tell us, hey, this marker is up. Maybe it's from mental health, this marker is up because of obesity. We're not there yet. You have nothing concrete. So the only thing concrete you have today to know your absolute risk is a CT scan. That's the black and white. It's been proven again and again, it's the most powerful thing to know. Everything else, we're talking about increased risk. Increased risk doesn't mean that you absolutely have disease. And that's where a CT scan can tell you whether if you're clean, that means yes, you may have risk factors, but it has not caused you a problem. And if it has caused a problem, then you take appropriate steps to tackle it. So like I showed you earlier, you can clearly make out blockages on a CT scan, and that's the way to know your own personal risk. Everything else is a surrogate. If you use blood markers, you do a treadmill test, you do all these risk scores of whether you're diabetic, blood pressure, they're all surrogates. They may be 70% off target actually. Most of the patients I've shown you would have come out clean in your regular standard testing. They would not be picked up. It's only a CT scan that helped highlight the problem in these patients. It's a very simple test, it takes about 15 minutes. There's a little bit of dye that's given, which can sometimes cause minor kidney injury, but very rare. The radiation dose is small, but the information you get can be life-changing for some people. And that's the question people ask them, right? Should we screen asymptomatic people? Should we all be getting our CT scans done, and why should we do it? So there are lots of studies answering that question. In fact, in 5 years, you will find they will not be doing any more risk cause people, they will be doing CT scans and working backwards. But I'll show you one study. This is about 10,000 people, same 40 years and above out of Denmark. Again, much healthier gene pool than us Asians, but this is in that pool. They took 40 or about 10,000 people, and so 54% had nothing. And this is where I kind of figure that quote my patients when I do for asymptomatic people. 36% had some disease, but nothing significant. But there were almost 10% who had actually critical blockage. And when they followed these people out for 3.5 years, the people who had significant blockages had an 8 times higher risk of having a heart attack. Makes sense, right? I mean, tight blockage, higher chance of heart attack. So very clear. That's why if you come to know your own individual risk, you can see where you stand in that. So this is what was happening in the past, right? You would wait for an event to happen. Once this plaque was silently growing in you for whatever reasons, then you have an event, then you wake up, then we start figuring out what's going on. In the past, maybe the last decade, people would calculate risk scores based on your age, your diabetes, cholesterol, smoker or not. Based on the score, they give you statins and aspirin and other medicines. And that is not, like I said, it's not a very accurate measure. So you may be treating, actually they've done studies, they're treating maybe 30-40% patients don't need any medicine, they will be still okay. And that's how the CT comes in, where you pick up very early disease and then treat the right patient with the right medication and figure it out. It's more information based. So how do we approach these novel risk factors? You of course have to first exclude the standard risk factors. You make sure people are not diabetic, hypertensive, smokers, or high cholesterol. If not, they propose some algorithms of questionnaires, blood tests to seek mental health, basically related problems. Again, there's no perfect guidelines, but you look for it after doing the other job. How does one reduce one's own risk, right? It's quite simple. You try to avoid the lifestyle-related risk factors, and that's what you go to any heart organization. They're preaching about the so-called life's essential 8. Exercise, control your sugar, weight, cholesterol, BP, smoking, and sleep. Sleep was added just 2 years ago. Before it was called life essential 7, now they made it 8. Sleep is very important. These are the targets where you want to be living if you're healthy. There's some, you want your blood pressure to be 120/80, you want your LDL to be below 100. A lot of people think they run around 130, that's okay because the lab says it's near optimal, but it's not. You really want to be below 100. In fact, they study people in the blue zone of the world who have no heart disease, their LDL is between 40 and 70. So the lower the better. Weight. And if you see diet, physical activity, stress, sleep, they're all subjective. You can't put a number on it. It's a very subjective thing. So you have to make a very personal effort to try to get this right. There's no one can ever be able to pinpoint that you're doing a good job or not doing a good job. And why is this promoted? Because all these things suppress chronic inflammation. By practicing this, you are decreasing inflammation in your body and hence the risk of heart disease. So this is the medicine for decreasing inflammation, healthy living. Back to him. So I saw him for 30 years with heart disease, or 35 years while growing up, and I didn't make much of it. I said, wow, great, he's had a great quality of life and it's pretty amazing. He went to the hospital twice, once for his open heart, once for his stent. The last time when he felt sick at 103, but between that, nothing. And the only thing was, to him, pursuit of health was pursuit of happiness to him. Literally. It has to be a calling from you. No one can make you, force you to live healthy. It really has to be a personal calling that you want to live healthy. And that's the only way you can be disciplined. And we have to all map our own journeys of how we want to live a disciplined, healthy life in this urban jungle. There is no one can, teach you that. So it's an inner calling, self-realization, and that's what it takes. If I have to, they've done surveys of these, healthy living. 90% of us don't meet all 8 criteria. It is not easy. It's easier said than done, but it's what it will take for you to improve your longevity, health span, lifespan. That's what it will take. So yeah. So in summary, guys, there's a rising lifestyle-related novel risk factors for heart disease. Inflammation is what's central, tying all these novel risk factors to heart disease. Mindful healthy living is what will make you reduce the risk. And CT scan is the test you should do all to understand your individual risk. Thank you.
If anybody has any questions, please feel free. We are aware. Yeah, go ahead.
The doctor, thanks so much for allowing on a presentation. My question is with regards to CT scanning of the heart. How often would you recommend we do scanning? Like
Right.
once a year or twice a
Yeah,
year?
yeah. So I tell people, if your first scan is clean and you're generally living healthy, it can give you a warranty up to 3 to 5 years. Yeah, you don't need to repeat. Now, if someone has disease, depending on the extent of disease, then it's an individual tailored journey, but clean scan, and if you're living well, at least quite reassured.
Thank you.
There is a saying that doctors usually say, I've heard some, they don't prescribe tablets for reducing your cholesterol. So how far this is true?
Say again, you see the doctors say,
Certain, for certain people, medication for cholesterol, for reducing cholesterol, it's not recommended.
Yeah.
Is that true?
again, it depends what the levels are. So let's say, and that's where CT helps. Let's say some people live at 110, 120 or 100, right? If you already have disease, you definitely need the medication. I have some people who live a very heavy life, but their LDLs are running like 110, 120. But the CT is having no disease and they don't want meds. It's okay because their overall lifestyle is counteracting even that little bit of high cholesterol. But yes, if you have disease, definitely you need the medication.
One more question. What type of people are recommended blood thinner and how is it connected with the heart?
So heart attack is, how they have a blood clot which forms in the arteries. That's what causes heart attack. Plaque rupture and blood clot. So people who have blockage, not even severe, just mild moderate, they should ideally be on blood thinners. Now, they have seen over the years, if you take aspirin for a very long time, then maybe you increase your risk of bleeding. You have to choose the right patient population. So let's say if your calcium score on a CT scan is about 100, then definitely the benefit outweighs the risk. Just remember, every medicine we are prescribing, there are always going to be some risks. But the only reason you're taking it is because the benefit outweighs the risk. Similarly, you pick the right patient. People clean arteries, no need for blood thinner. But if you have disease in a certain amount of spectrum, depending on your other risk factors, then definitely you will benefit more than the potential risk of disease.
Well, how is it vaccine, COVID vaccine? Some say it's related to your heart. How is it
Again,
related?
No, it's about an inflammatory reaction that it may generate in some people. So most of us have benefited because when you had COVID after that, the severity of COVID was much reduced. So it had generally been helpful. But yes, I had some people who came with COVID, related myocarditis, inflammation of the heart muscle. Some actually came with a heart attack. But it's a very few number. And it is because an individual body's response to the vaccine cannot be determined. And there'll always be a few who may have a very, deviated response which actually hurts them and hard to predict that.
Thank you. How early should we, I mean, we have kids, they're youngsters, how early should we do this?
So in general, if you have no risk factors, generally, I think 40 and above for males and 50 and above for females is a good time to start because women, their estrogen is cardioprotective. So early on, they have lesser risk of disease, but once they hit perimenopause, they start catching up pretty fast. So 40 and 50 is reasonable for normal people. Now, if you already have raging risk factors otherwise, and depending on the situation, then you can always consider it early. I just had someone who's 26 years old. He has read and heard so much on social media, and his parents have heart disease. He was paranoid. He said, I want to know. And it's okay for him to know. And we should find that since we have the technology, yes, there's some radiation, but it's not that bad.
So with this calcium scan and CT scan,
Same, calcium score is a part of the full scan. So if you just did the calcium score without the dye, then you only see the calcium, which is only so, and people who are young generally won't have calcified plaque, they have soft disease. So there's a lot, or 10% patients will have zero score, but they have disease which you'll miss if you only do a calcium score. So ideally, the perfect test is the full scan. If you're very, concerned about the dye and the extra radiation, at least a calcium score will start with, but it's not perfect.
how early?
Yeah, Poonam, go ahead.
Doctor, is it true that intermittent fasting stop happening?
No, someone sent me an article also. You have to read, the devil is in the details. It was a very small study. It was not totally correctly interpreted. They took just a few things out of context and made it sound. I mean, intermittent fasting has its own benefits. But yeah, this whole thing about intermittent fasting, there was one study, about 200 people in it, billions to do intermittent fasting. And it's worked for them. So in fact, some bigger articles published talk about improving insulin sensitivity by the fasting, but it's not for everyone though, right? But yeah, you're okay to do it, and it's not really going to increase the risk of heart. Yes, but very much same through the process of chronic inflammation. Because autoimmune disease, be it rheumatoid arthritis, inflammatory bowel syndromes, lupus, all these rheumatological problems, they are considered, you are supposed to consider as a risk factor for heart disease for sure.
Doctor, I have a question. Many people, today say that the vaccine, COVID vaccine had a really bad impact, on our health and, one of the reasons for cardiac arrests. Is that true or is that a myth?
No, it did cause, like I was explaining, some people have a disproportionate response to that new, substance, like a foreign body, right? The vaccine that we introduce in someone's body. So some people have a hyperimmune response, they call it hyperimmune, where such inflammation is working against you. But again, it's a very small fraction of people. And the reason it was continued to give and is still giving it because the overall benefits of it mitigating the severity of infection outweighs the small population, which we don't know. So you'll be dividing maybe 99% people of the benefit because some people will have a problem. And that can happen with anything, but nothing else is as social media publicized as much as COVID vaccine. That's why it's much more, talked about in the press. But yeah.
The risk of,
The risk, yeah. So it's the iodine-based dye, the same dye used for all your CTs. The statistical risk 1 in 10,000 of some allergic reaction or some kidney injury from the dye. So young, healthy people with normal kidneys, extremely unlikely to have any damage. You hydrate well pre and post, it's totally safe. yes, as you get older, and you're diabetic, or you have mild kidney disease, then yes, your risk may be slightly more, but still, it's negligible.
Doctor, we have two questions from
From the
people who are
online.
attending online. Can stenting be a substitute for more than 99% blockage in all arteries? And second question is there any advancement treating blockage other than CABG and stenting?
Yeah, so if your blockage is severe, there is no medicine yet to dissolve it or to, get rid of it. If you have, so yeah, any blockage that is severe, like 80-90% and above, there's no way to make it lesser. And especially, so I tell people when I meet them, now if you're a 80-year-old who's generally sitting home, not a very active lifestyle, you're on medications, don't want to take a risk of procedure, it's fine. If you have no symptoms, you can be. But young people who are active, going about their normal work, traveling, playing, that strain on your heart muscle when you're pushing, you never know when did you create the problem. So there are a lot of people who have come, they'll say, I don't need this stenting, I'm okay. They turn around in 3 months because it's like walking around with a guillotine on your head. You want to go for a run, you want to go play, then you are worried. So for those severe blockages, it's either bypass or stenting, depending on what's the right treatment for that particular person. But for mild to moderate disease, yes, aggressive treatment, and if your LDL goes really low, below 70, they have shown studies where this plaque can regress. It can get better. I actually had one of the cases, I don't have them here, that I did a CT around 3 years ago, and now, with all the changes, the plaque has actually resolved some. It won't totally eliminate, but yes, it can get better. And I didn't get the first question you talked about.
The first question is, can stenting be a substitute for more than 99% blockage in all arteries?
Can it be a substitute?
For
Can stenting be a
99.9%.
substitute?
I mean, it is the treatment. You can't substitute it.
It is the only treatment.
Yeah, there is you can't substitute them.
This cholesterol coming down as a borderline, we start medicine or?
That's why I said CT helps to know your thing. Right? If you're generally a healthy living person and you have no evidence of disease, you can say, no, I don't want to take it. But if you already have shown early disease, then you should definitely take it because A, it reduces your total cholesterol, which might improve your plaque. B, the cholesterol medicine actually helps to calm the plaque that's already there, prevent it from causing heart attacks. And they clearly shown that when you take these patients over 10 years, the curves separate. People on statins and non-statins in terms of the risk of heart attacks, people with disease. So yes, CT would help you make that answer. But if you had to ask me, so now how they're talking about this, I told you about the blue zone, right? People that are living till 100 years of age and have no heart problems, their average LDL is 40 to 70, which is really low, hard to get. They've started a new study now in 20-year-olds from 20 to 39, forget 40 plus, where they're checking their LDL levels. If it's above 70, they're either giving them medicine or saying live your normal life, because they know that if you stay on that higher cholesterol over time, you will definitely have a higher risk of disease than someone who's staying low. So lower is better. The conflict comes whether it's the pharma or the industry pushing medicines you take versus it's truly helping your health. But these studies generally don't lie. Or you can say maybe they are made in a manner to answer the question to the industry's interest. And that's your interpretation. But scientifically, yes, lower your cholesterol, the lesser your risk. But that's just one piece of the puzzle. And I just showed you, even if your cholesterol is normal, but other things are out of control, you can still have problems. So it is all those 8 things in sync, which will be your best prediction.
What is the target of cholesterol level? What's
So,
best?
yeah. So ideally, if you have no problems, it should be below 100, the LDL right now, which will change in 5 years to 70, but now LDL 100 is still acceptable. But if you already have disease, then depending on the extent, below 70 or otherwise below 55, people who have actually had stents, I push the below 40.
And the question is, how do you compare a CT scan with the conventional?
Treadmill. Treadmill, complete loser. Treadmill is the best guess on the outside. It's 70% accurate. So you can get 1 in 3 false positive, 1 in 3 false negative. It's like tossing a coin. I've been shown cases enough where the treadmill was normal, yet they had significant disease. You're guessing with treadmill. But it is what was there as a technology 30 years ago. It's not bad. It's a cheap way. Effective. Let's you really exercise very well. It's totally normal. You don't have any risk factors. Yes, in that context, it may be okay. But yes, now having seen so much of the CT scans, I've done a sound CT. I tell anyone if you have to, you start with the CT first. And then treadmill has certain areas where you can do. But yes, to answer your question, CT would be the best choice for you. Because it doesn't tell you the exact factor. Treadmill just tells you 0 or 1, positive, negative. The negative can also, positive can be falsely abnormal also. And it doesn't really extend the disease.
How about OD report?
2D echo is just telling you about your heart muscle. Some people who have heart disease or blockages may have a part of the muscle weak, but most of the time they don't have it. So it's a very insensitive test to look for blockages. No, see, depends on the hospital. They'll have a 256 slides or 64. That is for the resolution. But higher the slice cut, it's more fine. But, 120 is much better. Yeah, and then now the 256 slides. Yeah, I'm not up to date on what they have there, but yeah, it just goes what the hospital has there. Yeah, still decent. Clean is clean. You get, 64 rupees for a clean scan.
Oh,
It's a very individualized question in your circumstances, once you're 40 plus, depending on your lifestyle, maybe every year, 2 years, youngsters, maybe, every 2 to 3 years. Again, there's a lot of factors that you consider on that. But yes, generally 40 plus, your annual health screen, it's okay to keep an idea of where you're doing. But if you're so recommended in your full lifestyle that it's consistent the same every year, then yeah, you can do every 2 years because you know exactly what you're eating, how you're living.
HbA1c.
I mean, they take fasting, again, it'll depend on the lab. The lab that. No, A1C is 7 in elderly, and the younger patient 6.5 because elderly, if you're too aggressive, sometimes you get hypoglycemia. So 6.5 is the decent target. Fasting sugar, I think it depends on the lab. Some call it in millimoles. 125 is one of the units I've seen, and it depends. The lab will have the range for it. That I would know. There are so many technologies in that space, right? But they'll have their own reference range. Yeah. Not cholesterol, but there's some noise about uric acid and inflammation. Because uric acid causes gout as well, right? So there is some talk around it, but they have not able to figure it out of what to do with it. Even if it's high, but it's not causing any problem. Yeah, so we're still figuring it out. But yes, it's one of the markers which they are actively trying to understand better and what to do with this high.
We have another question there. Yes.
The test called homocysteine.
Homocysteine, those are.
So how accurate is that?
Again, it's not very accurate. Some people with high homocysteine levels are prone to maybe developing more risk of blood clot. They don't know exactly what causes it. Most of the time, it's a nutritional deficiency of folic acid and B12. So that's the most common. You correct for that. But let's say you correct for it, and if it's still higher, they've done many studies. They have not said they're not able to pinpoint it's really causing heart attacks. So again, just like uric acid, it's in that space of it may be, maybe not, but they're not able to confirm on it. But yes, if it's high, check your folic and B12 levels, because if they are low, then you should definitely correct for that. Especially vegetarians, they are prone to more having low folic acid. So
Let's say, if we go for a stent, let's say, I have a heart problems and if I just- how will that change my day-to-day life? Like, let's say I play badminton and I'm doing rigorous sport.
you can do much more of it because now you have nothing to worry about. Your pipelines have been all cleared, right?
It's as normal as
More than that. Yeah, no problem at all. You can go back to doing everything with much more confidence and carefree because that physical blockage has been taken care.
like, let's say, a couple of my friends are got stent. So basically, they are just reduced the level of, like, we play badminton. So they are trying to take little lesser stress, you know.
No, a lot of people tell me that they ask me about what should be my maximum heart rate if I have, but logically, if you have no active blockage, right? If your disease is well controlled and the blood flow to your heart muscle is adequate to keep up with the stream, it should not be a problem. And the same question I've asked for healthy people that how can my heart rate go to like zone 5, zone 6? I said, if that was a problem, there would be no competitive sports in this world because everyone would be, right. So it doesn't. And again, you have to scale up. There's going to be no perfect answer for this. Let's say someone got a blockage, you got a stent. You scale up with physical activity, and if you can tolerate, it's totally fine.
It just breathe.
Yeah.
There's no.
There's no, yeah, as long as you have no active blockages, job constant.
Now there is I just heard something, there is like, there is some liquid therapy. Like you don't have to put stents, you just have fast to liquid through your veins. Is it how?
That's the Drano equivalent you're talking about, right? People say it's like you put Drano on a drain, it cleans up. No, you don't have that yet. Nothing of that extent.
How do you convince some elderly people who think or claim that they're healthy that they need to do a CT scan?
See, you already talked about elderly people. So elderly people, I tell the kids, because that's a different bracket. They are living in, they're comfortable, they're peaceful, they feel they've lived their life, right? And I don't push elderly people because sometimes ignorance is bliss. So you got to pick your patients where you think you might make a difference in their lifespan or health span, and versus the elderly who probably have disease. But yeah, it's some want to know, and some are like, don't come close to me, just let me be. I just want to live the way I am, and you just have to respect it. I mean, these are choices.
I'm not saying like super elderly, like
60s, 70s,
60s.
50s are for sure.
I was going to say that for the least
50s are elderly. Come on.
50s is the new 30s.
Yeah,
My parents, their friends,
100% they should do it.
Yeah, how do you convince them? They think they're okay, they're asymptomatic.
If you're to come here, maybe I could have. But I'm just
Some
saying,
of their friends are here.
no, but it's an eye opener. But like I said, some people are very fixed in their fields. I mean, you can't fight it. You can always appeal to logic. If they understand the logic, they don't want to run into these surprise problems. Some look at it from that angle. Some say, I don't want to know what's happening inside. I feel good today. I'll deal with it when the day comes. That's the philosophy of life. I mean,
Doctor, actually, I have one question on your statement of mind, the ignorance part. There was a time when I was going through, a lot of stress because of my work. And one day it went a bit high. So I went to doctor and he told me your BP is high. Then he told me don't take medicines, but just monitor it. So I bought that machine and every day I used to monitor. Then my doctor from India said, throw that machine. Okay, don't ever watch it. And from that day, I never watched it and I never felt anything uneasy. So I don't know right now whether my BP is good or bad, but I don't care. So is it good, bad? I don't want to see what is my BP.
if that's how you want to do it, it's your call. But I'll tell you, the biggest risk factor for heart disease is uncontrolled BP because you don't feel it. You don't feel BP, you don't feel cholesterol, you don't feel sugar. They are just doing their job silently. And the day they attack, then they propagate that. Now, as we get older, it's not really the age which is the risk factor, it's the cumulative exposure of these risk factors over time that increases the risk. And of course, with age, your arteries will become a little stiffer, there is a little higher blood pressure. Some people get hypertension, it's run in the families, some it's a lifestyle thing, high salt, our food diet. You know, there's actually a study out of US called the Masala study, where they say just because of the spices and our diet, our BPs tend to run higher just from that, right? So you may not feel it, you only feel it when it's really high. That time you have headaches, you have other problems. But by that time, you could have done so much damage you could have prevented. Yes, you can't get obsessive over checking and stressing out about it, and then it will keep climbing. I mean, yes, there is that whole thing called white coat syndrome. When you go to a doctor's office, it's super high. Back home, it's back to normal. So you have to kind of work your logic a little bit and don't go on either extreme. Yeah. You have to find a balanced approach. But yes, you just can't go without checking your blood pressure till end of life, because the end of life may be much sooner than you think then. That's all.
This LDL bad cholesterol and HDL is good cholesterol. Having good cholesterol high is.
They call it as a counterbalance, but it is not a substitute for having high LDL. So you just because you have a high HDL, you can get away with a high LDL. No, that's very doesn't.
It's been 85 to 90.
Everyone is different. And there are a lot of factors that go in it. From your own condition status, your diabetes, to other problems, it may create a slightly average resting heart rate is 60 to 80, but that's some people on the 10% spectrum are really higher, some are really lower.
Like my one is resting heart rate is always 80 to 85.
Yeah. I mean, you have to get into the devil in the details of other risk factors, what is going on. Was it lower before and it's become higher now? And what has changed there? Yeah. It's very tough to just give you an answer on that one number, but a lot of people live in that, it's okay. It really is more than an individual, details.
We can take only last one question here.
We're talking about certain people taking less of oxygen while sleeping.
The sleep apnea, yeah.
So why does that happen and what is the condition?
Most common reason is obesity, because obesity is a lot of neck mass that they develop. Right? And as you get into very, very deep sleep, as your muscles relax, because the weight just shuts on you. As it shuts, there's less oxygen going in. So that's how less oxygen, and you wake up, but you never remember that you've woken up, and your deep sleep is never smooth because you're going through up and down in it. And that's how it happens. That's the most common mechanism for this sleep apnea.
Last question, yes, Rajan.
Thank you. Sir, I'm 80 plus. I've been smoking since the age of 14. I'm super active, socially and professionally. Travel the world about 7-8 times in a year. Speech constantly. No sleep problem, no cholesterol problem, no diabetes. Alcohol, social drinking. What should I stop?
It's too late to stop anything.
Thank you so much. Thank you so much, Dr. Yeah, thank you so much, Dr. Rastogi, for this enlightening session. I would request Poonamji to give a token of appreciation to Doctor.
Thank you so much.
Thank you, guys. Thanks for coming. I mean, it's a Saturday afternoon, so I hope I made it worth your time, but these are good things to know. So, thank you. Thank you.
There's tea and snacks at the counter.
Also, I'd just like to put in a little thing that Dr. Saurabh is here tomorrow as well. In case you need a private consultation, he's available from 9 a.m. tomorrow till 3 p.m. at JW Marriott at the Business Center. But there is in the invite that we had sent you, there is also a link to take the appointment. So please fill that link. It's a Google form. So if anybody, and yes, Dr. Saurabh is still here. If you'd like to talk to him, over to him. Thank you. Thank you all for coming.